thank you very much, Little Steps, for inviting me to speak to you on the topic of the impact of Duchenne muscular dystrophy and steroids on bone growth and puberty. My name is Dr. Jarod Wong. I'm a consultant pediatric endocrinologist based in Glasgow, UK. So this next slide shows you what happens during childhood in regard to muscle and bone growth development. Bones grow all throughout childhood, and it's mainly driven by the growth of muscles, and this is mediated via physical activity, in particular high impact physical activity like jumping. This leads to bones to become thicker and stronger. As children grow and as children go through puberty during their adolescence, cells at the end of the long bones called growth plate, under the influence of hormones like growth hormone and puberty hormones like testosterone in a boy, increases these cells that sit in the growth plate so that there are more of these cells and these cells become bigger, which then makes the bones to become longer. In due time, blood vessels come to this area and it turns these cells into bones. And therefore, as children grow well and go through puberty, bones also become bigger and stronger. We do know that bones are also made of different minerals and nutrition like calcium, which is contained in dairy products, and vitamin D, which we can make vitamin D by spending time in the sun, is very important to improve the minerals in bones. Therefore, during childhood, as muscles develop through physical activity, as children grow taller and with good nutrition, bones can become stronger and thicker. On the other hand, we know that steroid medicines like prednisolone or deflazacort, which is used in boys with DMD, whilst very useful to improve muscle strength, prolongs ambulation, protects the heart and the lungs, can have a direct impact to weaken the bones. We know that steroid medicines like prednisolone and deflazacort also impairs growth and stops puberty from happening by making the hormones not effective, which is produced by the body. And as a result of poor growth, this also again leads to poor bones. We also know that prednisolone and deflazacort can impact on the absorption of calcium in the body. And vitamin D levels are usually insufficient in boys with Duchenne muscular dystrophy because they may not spend as much time out in the sun. Therefore, the underlying muscle weakness itself and the use of steroids, either directly weakening bones, affecting growth in puberty, or affecting the absorption of calcium, can lead to poor bone development for boys with DMD, and this leads to a state of weak bones, or what we call osteoporosis. So what is osteoporosis? Well, osteoporosis is weak bones, but the end result of it is that people will suffer a fracture or sustain a fracture, especially with very minimal injury. In a recent study in a group of boys with Duchenne muscular dystrophy in Scotland, we found that at least 50% of boys will sustain a fracture. About 30% of these long bone fractures are fracture of the femur, of the thigh bones, which is uncommon in healthy children. 60% of these long bone fractures are due to minor falls, for instance, just fall from standing or fall from walking. But interestingly, what we saw was about 25% of these long bone fractures are from boys in a wheelchair who fall from a wheelchair. Therefore, the important message to try to improve bone health and protect bone health in boys with DMD is not just some of the medical, nutritional strategies, but wheelchair safety is also very important. Spine compression fractures or vertebral fractures are extremely common in boys with DMD. The vertebrae or the backbones are usually rectangle in shape if they're healthy. These bones can't break into half like a long bone, but they can be squashed or compressed, as you can see in this picture, the middle vertebra on the left. About 10 to 20% of boys with DMD on steroids have spine compression fracture, present with very bad back pain or significant back pain. Some boys can have minimal back pain or no back pain. But if we do these x-rays of the backbones of the vertebra to screen for these fractures, we can see they are present. So if vertebral fractures are present, this signifies that the bones are very fragile, and therefore treatment for bone health is necessary. And the new updated standards of care recommends that rather than waiting for these boys to present with significant back pain, we should be proactive and periodically do these x-rays to screen for vertebral fractures. So in this slide, you can see a picture of 3 x-rays of 3 boys with DMD. There are x-rays taken from the side on of a boy with DMD. You can see that on the left, you've got a boy with normal spine where the vertebrae are all rectangle in shape. They're nice and healthy, where there are no fractures. On the far right, you can see a boy who has severe vertebral fractures with almost all the vertebrae affected because they're no longer rectangle, as you can see. Some are squashed in the middle to some moderate degree, and some actually squashed a lot in the front and which have severe fractures. The boy in the middle, on the other hand, actually has got some mild changes of vertebral fractures. As you can see, some of these where they are slightly squashed, but not severely. But these will be missed if we do not do these x-rays. So these x-rays need to be done to look for spine compression fractures. Some of you may be more familiar with the DEXA bone density scan, which is performed for the last 5-10 years as part of standards of care, which allows an estimation of how strong bones are. Some of these new DEXA scanner or bone density scanner also allows good quality enough pictures to be able to diagnose vertebral fractures. And it is possible that your hospital has these special bone density scanners. So what do the updated standards of care now recommend, which is published in 2018? It recommends that all boys with DMD should have routine imaging of the back to screen for spine compression fractures. Of those on steroids, this should happen every 1 to 2 years, and those not on steroids every 2 to 3 years. The bone density scan should be done about once a year, but the standards of care recommends that you should prioritize the use of x-rays to look at these vertebral fractures rather than doing bone density scanners. Not every hospital has a bone density scanner, but every hospital has an x-ray machine. When do we then start bone protective medicines or bisphosphonate in boys with DMD? In the presence of a long bone fracture with minimal injury or evidence of spine compression fractures on these x-rays, even without back pain, a referral to an endocrinologist or bone specialist should be made to discuss the use of these bone protective medicines called bisphosphonate to be started. And this should now happen. I'd like to next go on to growth in boys with DMD. We know that about 25% of boys with DMD are short even before starting steroids. No doubt steroids cause poor growth and growth failure. Growth hormone therapy is used in some people, but there's very little evidence. And in the updated standards of care, it is not recommended routinely. It requires daily injections, and the positive effects is only perhaps slight improvement in growth rate, but the boy still remains short, and there are some side effects. So unfortunately, currently, we do not have very effective therapy to manage short stature or poor growth in DMD. Puberty, on the other hand, is very useful and important to address. On average, healthy boys start puberty about the age of 11. The majority of boys with DMD, especially those taking daily steroids, will not start puberty even by the age of 14 or 15 or later. The male hormone of testosterone is important not just to cause changes associated with puberty. It can, of course, lead to the growth spurt. During adolescence, we also know that testosterone is important for improving bone health, muscle, and also for self-esteem, because a lot of times these young men or adolescents with DMD do not want to look younger compared to their friends. So what does the updated standards of care now recommend? It now recommends that assessment of puberty should be done from about age 9. In the UK, we feel that it is more realistic for this to be performed from the age 12, simply because testosterone treatment to address delayed puberty is usually started at the age of 14, although can be considered from the age 12. This can be given as injections, gel, or tablets. And there is now a few studies which show that testosterone for managing puberty in DMD is safe and well accepted. It leads to some improvement in growth rate, but not a large amount of improvement like the 20 centimeters that we see in healthy boys. The research also shows that it can stabilize bone density, and there's some new research which shows that it might actually show some improvement on muscle MRI. So this is an important area to address. The next couple of slides talk about the types of steroids and the side effects that we can see. I'm sure most of you already know that the efficacy between daily steroids and intermittent steroids, or 10 days off, 10 days off. This study from the UK shows that boys on daily steroid, after a 2-year follow-up, 20% lost ambulation and non-ambulant, but those on intermittent steroids, 40% were non-ambulant at 2 years. So it seems like daily steroids is better in terms of muscle outcome, but there are side effect differences. In those treated with daily steroids, 40% had spine compression fracture and 4% had long bone fractures, whereas those on the intermittent steroid group, only 8% had spine compression fracture, lower, but doesn't mean that it was zero. But in the 2-year follow-up, none of them had long bone fracture. What the study also showed, which other groups have shown, is that boys on daily steroid were shorter and heavier than those on intermittent steroids. So certainly there are some risk-benefit issues to consider. In some research that we are doing, we have found that puberty is almost always delayed in those on daily steroids. Puberty usually happens in those on intermittent steroids, but may just take slower to complete. Other than some of the endocrine and bone side effects that I've discussed, we know that there are different side effects of steroids as well. And it appears that if comparing prednisolone and deflazacort, there might be some side effect differences, but this does not mean that it's always present in everyone. Weight gain, sleep disturbances, and mood and behavior changes appears to be more common in those taking prednisolone. Poor growth and eye problems like cataracts appear to be commoner in those on daily deflazacort, with some of our recent work using the North Star database suggesting that perhaps fracture may be commoner in those on daily deflazacort. Some, if not a lot of you, will know about the 4DMD trial, which is a randomized trial recruiting boys from initiation of steroids into daily deflazacort, daily prednisolone, and intermittent 10 days on, 10 days off prednisolone has been completed. And it may give us some results on the efficacy and side effects of steroids in the first 3 years of treatment. So there are some issues on efficacy and benefit which needs to be answered, and it's not a straightforward question. So the next couple of slides just shows you where you can get information on the updated standards of care. On the Treat NMD website, there are family guides of the 2018 standards of care, which you can look at. World Duchenne Organization has a YouTube channel with short 2 to 4 minutes video on various aspects of care based on the standards of care. In the UK, together with Duchenne UK, we launched a project called the DMD Care UK, which aims to implement standards of care in the UK with some information leaflets that you could look at. So to summarize, hopefully in this short talk, you can understand that the different steroid regimen and type can have an impact on muscle outcome, but also side effects. And these are discussions that family and clinicians need to have on what's the right regimen. We know that spine compression fracture is very common in DMD, and now the routine imaging of spine is recommended so that treatment can be started once we identify them, even without back pain. Adolescent boys often, or in the majority of those on daily steroids, have delayed puberty, and assessment of puberty routinely from the age of 12 at least is now part of standards of care. And treatment of delayed puberty with testosterone should also be recommended as part of standards of care. Thank you very much once again, Little Steps, for the opportunity to share this information with the DMD community. I hope you gain something from the talk, and please enjoy the rest of the amazing conference.